We now recognize quite clearly that AML is not one disease, it's many diseases. And that's based on both the age of the patients, their performance status at diagnosis, and the disease biology, which is extremely important. Disease biology can be described in terms of the different cytogenetic abnormalities that patients have, ranging from favorable to poor, and then there's intermediate. If you also look at the genetic landscape at the time of diagnosis in an AML patient, you'll see that you can modify the cytogenetic classification into more precise categories. Moreover, you might also be able to think about the different pathophysiology of the different subtypes of AML according to which mutations predominate in a given patient. For the last few years, we've been thinking about several different important subtypes, chiefly because we have targeted agents that might be useful in those subtypes. One of the most common, if not the most common mutations in AML is FLT3, which is a transmembrane tyrosine kinase that's mutated in about 30%. These are activating mutations. So if you have a mutation, the gene is always on. It does not require cognate ligand binding, and you're off to the races in terms of becoming a leukemia cell. That's an activation mutation, as I mentioned, so it's targetable with things like small molecules, just like the BCR-ABL activated tyrosine kinase has been successfully targeted in CML. Another important subtype of AML are patients with IDH mutations. This is a less common subtype of AML. About 9% have IDH1 mutations, and about 12% have IDH2 mutations. These are very interesting enzymes because they're involved in oxidative decarboxylation, or what's commonly called the Krebs cycle. It's a little surprising at first that mutations in one of these metabolic enzymes might produce leukemia, but they do. It turns out when either of these two enzymes are mutated, it produces a neomorphic reaction product called 2-hydroxyglutarate. When 2-hydroxyglutarate levels are high, the epigenetic milieu of the DNA changes. It becomes more like the situation that occurs when you have a TET2 mutation and the cells have trouble differentiating. So that is also a gain of function mutation in the sense that it produces 2-HG. So that can also be targeted with small molecules. So that's both the genetic heterogeneity idea of AML and also the reason we've been busy trying to target FLT3 and IDH respectively.